Greetings. Let us talk about pneumatic balloon dilation for achalasia cardia. Achalasia is characterized by a dysfunction of the lower esophageal sphincter which fails to relax. And also, when you look at the main esophagus, it is characterized by peristaltic failure. So the sphincter doesn't open, the esophageal body cannot pump. And with that, the patient will have difficulty swallowing both liquids as well as solids. And when you do an endoscopy, the lower esophageal sphincter is tight, and this is the tightness that you want to disrupt with the pneumatic balloon dilation. And let us learn about how do you set up for pneumatic balloon dilation. We need a pneumatic balloon dilator setup. It has a balloon, it has a pump that pumps in the balloon with air, and there's a measuring device. And there is another outlet that allows a guide wire for the balloon to pass over a guide wire. And we need a Savory guide wire that is inserted into the stomach, and over the guide wire, this balloon catheter goes directly into the esophagus and across the GE junction under fluoroscopic control. We also need a little bit of lubricant to lubricate the balloon and a gauze to apply the lubricant. When it comes to balloon catheters, there are three sets: a 30 millimeter balloon dilator, 35 millimeter balloon dilator, and a 40 millimeter balloon dilator. Typically, we go with the smallest balloon starting at 30 millimeter size. If that doesn't work, after 3 to 4 weeks, they go to 35 millimeter balloon size for dilation. We don't go to 40 millimeters to start with, because the risk of perforation is very high with the bigger balloon. Patients are typically positioned on a fluoroscopy table and done under general anesthesia. And the first step is to do endoscopy to clean out the esophagus that is filled with saliva and sometimes food that is not emptied. Once the endoscopist cleans out the esophagus, then he inserts the guide wire into the antrum and then removes the endoscope. Before the endoscope is removed, the endoscopist places a marker on the chest of the patient to localize the lower esophageal sphincter. Usually, a safety pin or a safety clip or a metal clip is attached to a tape and then placed on the chest to mark the lower esophageal sphincter. And this marker is used to keep the center of the balloon just across that marker under fluoroscopy. And after doing that and removing the scope, leaving the guide wire in place, the balloon catheter is passed over the guide wire to across the GE junction that has already been marked by a marker placed on the skin. And the balloon is slowly inflated until the waste disappears. Once the waste disappears, you typically keep it for 60 seconds. There is one study that shows that even 6 seconds works. And following the successful dilation, the balloon is deflated and the balloon catheter is removed while leaving the guide wire in place. Some endoscopists leave the guide wire, some endoscopists remove the guide wire. There's a difference in practice. And after that, it is important for the endoscopist to check if there is a perforation with the scope. But some do check, others don't check. And they all end up receiving an esophagogram to see if there was a perforation. If there's no perforation, the patient will be encouraged after 24 hours to have some liquids by mouth. Coming to the adverse events of pneumatic dilation, there's include chest pain, perforation, and rarely bleeding. Thank you.